Good morning, everybody, or good afternoon, or good evening. Again, thank you all for joining. We'll start in a few minutes. We're going to have a lecture by Kitty Pong on craniocervical junction. Following that, we'll have some cases. The waiting room feature today seems to be enabled, so there's no particular great way to disable it without a passcode, so we'll deal with that later. So I'll be admitting people to the waiting room as it goes. All right, let's wait a few minutes and then we'll get started. All right, thanks for joining, everybody. Let me stop this. Kitty Pong, thank you so much for hosting and for lecturing. We have a great lecture ahead and then some cases. People are still filtering in, so as they are, there's a waiting room thing today, so I'll be admitting people to that. But anyway, if you have any comments, anybody has any questions, comments, there's that chat thing, you know it, or speak up. Thanks so much. All right, let's go ahead. Kiripong, thank you again.
Okay. 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 Hello, everyone again. Okay. And okay, shall I start?
Yeah, I think let's go ahead.
Okay. So so we're going to talk about the. I'm going to share my screen. Okay. Okay. So it's going to be about the anatomy of the vascular anatomy of the craniocervical junction. Okay. So I can share my screen. Okay, so in the last session of BANANAZ, I think we talked about the vascular anatomy of the spine, which is on the left side of this slide, and we are moving a little bit upwards near the skull base at this craniocervical junction, which is actually it's kind of like a continuation of the spine and the anatomy of the brain. So it's a little bit similar to the spine, but has different aspects that it becomes very complicated with all the small stuff that you have in the spine and with other parts like the pica, the lateral spinal arteries, and some dural branches that you don't really see a lot in the spinal cord, although they share some similarities. Okay, so I'll just walk you through all the parts, showing you the pictures of what they look like, where you can expect these arteries to be. Okay, one of the important parts that we have in this craniocervical junction is the emergence of what we call the lateral spinal artery. I wrote here this posterior spinal artery. So the posterior spinal artery at the upper cervical level will become like 1 here at number 2 here down to this number 4. This is called the lateral spinal artery, and the other one will run posterior to the cord. You can call this one the posterior spinal artery. So it's not very much different, but whether it runs in front of the dorsal root or it runs behind the dorsal root, we name them differently. We'll walk you through this, okay? So as I've told you, the CCJ area is the transitional part of the spinal structure to the cranial structure. It's a little bit complex, and I think good understanding of anatomy of this area helps you to plan the treatments. I'll be talking about the arterial system and also a little bit about the venous system in this area. So they're kind of like very three-dimensional, and you know, you can take pictures of the screen. You can look at the lecture again. It's probably going to be on the YouTube again, okay, to review these three-dimensional things. Okay, any vertebral artery injection, you'll see something like this. All the small vessels around this area. You don't see a lot of things, but when you go look in a little bit more detail, you see a lot of things. So I'll just show you this illustration to get you the overview of the all the compartments, all the arteries that you should know to be familiar with the anatomy in this region. So we call this cervical spaces, the first one, the second one, the third one, and the fourth one. And there are segments of the arteries that run, that emerges from each segment, maybe from the vert, and goes into only maybe the dura, or sometimes they go into the intradural to become the artery of the central nervous system or the upper cervical cord. So we have these are not something that these are quite familiar to you. The anterior spinal artery, and here it is, the lateral spinal artery. It has various, origins. Usually we have the origin of the anterior spinal artery from this vertebral artery just before the union to the basilar artery. But for the lateral spinal artery, we have many sources, and there are a lot of variations that you should know, and sometimes it's related to the pica itself. Okay, there's another part to this. These are the arteries of the dura. As you can say, it will be spoken about again probably when we talk about the ascending pharyngeal artery. So this is what we call the anterior meningeal artery, or the odontoid arcade. Part of the odontoid arcade will have connections to the ascending pharyngeal system through this hypoglossal canal. And there are dural arteries in the posterior fossa that sometimes it becomes the feeder of the shunts in this area. One is called the posterior meningeal artery, and anything that comes into the posterior fossa, we have connections to one another. A lot of components there. You can see some parts from the ICA, some comes from the MMA itself, some of them come from the occipital artery, some are from the ascending pharyngeal artery, and so on. So such a small area, and so many, arteries contributing to the system. You can also have the ascending cervical artery, the deep cervical artery, connecting to the vert. These are also the intersegmental arteries, as like the vertebral artery is, and they can send this, segmental arteries to supply the dura or the nerves or the nervous system itself. Okay. So this is about all that we need to recognize when you see the angios. And actually, it's quite difficult to see all the small arteries when you look at the angiogram, especially on the 2D runs. So I've made this picture from the rotational angiography and put it with the bone like this. You can see the vertebral artery. So this is like a very good landmark that you can recognize very well. The others, I will put them in different colors to help you to see them easier. Okay, so this is, I've raised everything except the vert, and I'll put back so this is the opposite side. Okay, so magnify it a little bit, and we have this. So this runs above the dens of the C2. So this will be the anterior meningeal artery. So this is a dural branch. It doesn't feed directly the nervous tissue. Okay, so we put something else. So this is called the odontoid arch, or the dural artery in this area. So there's a pair of it on the opposite side also. So this is another component. It looks a little bit maybe strange to you, but this one runs in the midline, and actually there's another origin from here. So you can see the hairpin here. So this is actually the anterior spinal artery in the cervical area. Most of the time you can see they're not fully fused, so there are like two vessels running around to get together. Like a paired artery, which means that it's not fully fused as the longitudinal neural axis axial artery. Most of the time you see this in the cervical area, but in the thoracic and the lumbar area, this anterior spinal artery becomes one vessel. So this is in yellow. Okay, so another component. So this is something that is arising in this case from the segment of the C2 running horizontally to enter the dura, and gives one branch which runs downward, and another one which like an ascending branch which goes upwards. So what is this artery? It's not a dural artery anymore. It runs inside the dura. So this is actually the lateral spinal artery arising from, in this case, from the C2 segment. Okay. So make them turn, so that you can appreciate it a little bit in three-dimensional image like this. Okay, so there are some more components to this. So again, make it turn a little bit more, and we can add the posterior meningeal artery. In this case, I think it arises from the V3 segment, this red artery here. So this is everything, the major branches that we need to know in this area. Look at it from a side view. You can see the anterospinal artery here. The anterior meningeal artery, or the artery of the odontoid arch, is actually from the lateral view a little bit anterior to this anterospinal artery, because it's on the dura, okay? And this one is the lateral spinal artery. Okay, so again, lateral view, anterior view, and posterior view. So it's, well, not so many vessels, and it's quite comparable to the one you see in the spine, which this odontoid arch is actually like the one the anastomosis you see at the in front of the you know, what we call the retrocorporeal anastomosis in the spine level. Okay, so it's quite similar but different you know, aspect. So the lateral spinal artery system. What is the lateral spinal artery system? So it's it runs ventral to the dorsal root, and it's posterior to the dentate ligament along the accessory nerve. When we have a nerve, we have an artery. So like this lateral spinal artery is the artery of the accessory nerve. You can say it like that. And some of the times it can become part of the pica, or the pica can become part of the system, vice versa. So this is the drawing again from surgical neuroangiography, the book, and it's described like this. Okay, so it's like you have this ladder thing. Again, the extradural intersegmental connection will be the vertebral artery itself. The midline arteries will be the anterospinal artery, and the intradural paramedial, you know, longitudinal connection will represent actually the lateral spinal artery system. So this is the axis, okay? In cadaver, it's something like this. So it runs in front of the dorsal root. Usually it's difficult to see on the 2D angiograms. So anything you have in here, when you have a shunt or anything, it become more prominent. But there are some important messages that you need to know. Not everything you see is pure lateral spinal artery or pure dural branch. It can be a mixture of both. They can share the same origins, and you might not recognize them. You can have a large dural branch from the same source that also supply the lateral spinal artery also. And when you have a shunt only on the dura, the enlargement will be only on the dural branch, and you don't see the lateral spinal artery very well. You might inject something in there and end up embolizing the lateral spinal artery system itself. I will show you variations of this. It can be from any segment, okay? So this is a lateral spinal artery arising from, actually, we saw one from the C2, but this one is arising from the C1 segment, or the segment that at the entrance to of the vertebral artery to the dura, okay? So this one has a descending and ascending, and it's quite prominent because actually it's supplying part of the choroid plexus of the fourth ventricle, which is not, we don't see this very often. I don't know, maybe it's under-recognized, but once you look at it carefully enough, you can see this kind of, you know, connections, which is quite, you know, understandable, because it's only the longitudinal connection of the intradural paramedian arterial system. Okay, so this can be part of the pica also. I'll show you some pictures. Okay, so this is a picture that we can call, I don't know how you call this. Okay, we have a pica rising here. People might call this and like extradural pica, but actually this is not extradural. It enters the dura around this area because it has to pierce the dura to run and share similar course as the, the lateral spinal artery itself. And what's interesting about this picture, I will show you this in 3D again. So it's the same thing that if you've seen on 2D. Okay, so not a lot of new information. So this is just the pica arising from the C2. But once we put this in like a high resolution 3D, something like this, it looks a little bit messy, but I just wanted to show you a very small branch arising from here. I think it's better, I should stop the rotation somewhere. Not very easy to see, but I just want you to see this. It's not moving very smoothly, but there's a branch here coming from this part of the pica. I'll try to stop this one at the right moment again. Maybe this one is better. No, it's going too much. Okay, maybe it's a little bit difficult to see for you, but once this pica enters the dura, it gives the pica itself, which goes like upwards. And there's another small branch here, which is a little bit difficult to see. But this is actually like a descending branch of this system, which we can tell instantly. We have seen like an ascending branch of this lateral spinal artery system, and also it will give a descending branch. So the ascending branch has captured the territory of the pica, and the descending branch is just the ordinary, the normal lateral spinal artery. So it's smaller, it's difficult to see, but actually it shares the same origin with the pica, which means actually they're from the same system. You can say that the pica arises from the system of the lateral spinal artery, okay? So that's about the pica and the lateral spinal artery. It can arise from any level, from maybe the lateral spinal artery can arise from the pica itself, even though the pica is intracranial, or like the one we have seen from the C2 level, or even down to the C3 level, it's possible. Okay, so another system that you should be familiar with is this odontoid arch system, which is shown in red again. It arises from the C2. The last case, we've seen a pica arising from the same segment, but this one, it is giving this odontoid arterial branch, which is typically, we are taught that this odontoid arterial arcade will arise from the C3 segment. Typically, it will arise from the C3 segment, as we see on the picture on the right side, which is in light brown here. So usually it rises from here, goes up to here, make a loop over the dens, maybe get a connection through the hypoglossal canal with the ascending pharyngeal artery, okay? So typically it will arise from the C3, but again, we have the segment. You can have any kind of artery originating from any segments. You can have the pica, you can have these dural branches, you can have the lateral spinal artery from any segment. It is always possible. So in this case, it's not very common to see this, but this one is arising from the C2. And you can be able to tell, I don't know what this one was trying to. So this is typical appearance of this odontoid arterial system. This one is not in red anymore. It's in light brown here, okay? So the relationship to the other arteries are shown here. You can see the lateral spinal artery system arises from the C2 and also from the vertebral artery itself intradurally. Okay, so this is in axial view. So this is the odontoid arterial arcade starting here. There's another descending branch also, just like we have seen in the lateral spinal artery. Well, we have a supply that goes horizontally So once it reaches the target, which is kind of like running vertically, they will give one branch going up, another branch going down. That's not anything difficult to imagine. So it's something like this. This is a typical looking type of this dural branch of the odontoid arcade. You can see it goes up here. It's a little bit difficult to see, but you can see it has a small branch that goes, trying to go through the hypoglossal canal up here, okay? Again, so these are the branches that we should recognize. The anterior spinal artery is here on the MPR axial view. It's located here. The anterior meningeal artery is actually here and here, okay? And the lateral spinal artery is at the alongside of the, of the cord. So it's here and here in green. And there are dural branches. This is the ventral dural branch, and another one going dorsally. So these are the branches that can arise from anywhere, any segment, okay? A case of basilar top aneurysm. I don't know what this is going to show. I don't remember. So this is the one that was having the dural branch from the C2. So you can imagine anything from anywhere, okay? But when we look a little bit more in detail of this one, so is this pure dural branch? It looks like it, but in theory, it doesn't need to be, okay? It can give, again, like we see in the spinal cord, you can have a dural branch, and from that, it can share common origin with the posterior spinal artery or the radiculomedullary artery and so on. So this one, when we look a little bit more in detail, this is the same branch looking from anteriorly, and we will make this, change the resolution of the picture, going like that, and turn it around. You can see a small connection here to the pica already, and we'll turn it around a little bit. Okay, so it connects to here. So how does a dural branch, okay, connect to the pica? Okay, it's not difficult once you've learned that anything can share a common origin, and the the common artery that can share this kind of thing is, so that we can say this is a part of the lateral spinal artery system. So if you try to embolize this, what you recognize as a dural branch, and you don't see this very well, there's a potential that you can enter into the dura and hit the pica or the lateral spinal artery, and you can cause stroke by that. Okay, so this is quite scary to see all these small vessels connecting. Okay, so it's but the story is that the logic is not so difficult. So it's the same thing that we see in the spine. Anything can arise at any level. Okay, so another one in MPR, you can see the pica here, a little bit of connection to the dural branches. Okay, so the odontoid arterial system, usually it arises from the C3 space, but it also has connections to the C2, C1 segments, and also to the vertebral artery itself too. And sometimes you can give branches that participate in the lateral spinal artery system. So that's when you need to be careful, okay? So I don't think I should speak about this. Another component that we should recognize, because sometimes we try to embolize through these branches, but you get into trouble, is the posterior meningeal artery system. It's not actually at this craniocervical junction. It's in the posterior fossa actually, but it arises usually from this V3 segment over here. This one is feeding this AVM, so it's a little bit prominent. You can see it quite well. It has this medial branch that goes. You can say this is the artery of the falx cerebelli, and this is the another lateral branch. Usually we call this the posterior meningeal artery. This is the typical origin of this artery, but it can also have origins from Also the VA, the ascending pharyngeal artery, the occipital artery, and what we have been talking about, the odontoid arterial arcade from the vertebral artery. And it can have communications with many, other source of the dural branch that goes into the posterior fossa. But also, very importantly, it can arise also from the pica itself, and also from the intradural vertebral artery itself, which is these arteries are supposed to be supplying only the central nervous system, but no, sometimes it can give branches that supply the dura too. So the problem is when you do something to a dural branch in the area, you have the potential, you have the possibility, or do you have the danger to penetrate into these dural branches that connect to the pica or even to the intradural vertebral artery, okay? So I'll show you some examples. This patient has a shunt here at the nerve root at C maybe 4 or 5, but it doesn't really matter here because there's the important message of this picture is you can see here, this is the posterior meningeal artery going here all the way, and you trace it back here, and you can see that it actually arises from the pica, and this pica is actually intradural pica, the usual position of the pica. So it's just a subarachnoid vessel giving a dural branch to the posterior fossa and the falx cerebelli. On 3D, you can see it like this. So it's not just superimposing, it's really sharing the origin with the pica, which is very interesting to know and quite scary if you want to inject anything into these posterior fossa dural arteries. Okay, another one. This one is not that obvious, but again, if you look carefully enough, there's some, dural branch coming from here. You don't really see very nice the origin, but again, if you make a picture like this, you can see this one is arising actually from the intradural pica, not pica, but this is actually arising from the vertebral artery itself. The origin is even more distal than the origin of the pica. So this is like you are way intradural, and you can have this dural artery arising from the vertebral artery itself. Okay, so another point to be careful about. So these dural branches actually they can arise almost anywhere around the foramen magnum area. Okay. And there has been reports like this. This one, they were injecting onyx into a branch of the MMA. And as you know, the MMA also, has connections to the posterior fossa. So the onyx somehow reflects into this posterior meningeal artery. These arrows are showing here, and it's very small, the artery itself. And somehow it gets all the way into the posterior fossa like this, and the patient ended up having a lateral medullary infarct. So this is like the lateral spinal artery sharing this posterior meningeal artery, and you just reflux all the way to its origin. Okay, another similar story sharing the same logic. This one again, this is the pica. This is the posterior meningeal artery arising from the intradural vertebral artery. Okay, so they were trying to catheterize this posterior meningeal artery, but they had trouble, and somehow this artery got occluded. Okay, so although they didn't inject any glue or anything, the patient ended up having this the same type of infarct in the brainstem. Okay, so it's not the message is that these dural branches that you see, as I've shown you in the C2 segments and stuff, it's not purely. It doesn't mean that they are always pure dural branches. they can share the same origin with the branches that go to the brainstem or the upper cervical cord. These posterior meningeal arteries can be quite tricky. This one is usually the usual origin of the odontoid aerial arcade, but this one actually goes all the way into the posterior fossa to become the posterior meningeal artery, which it arises from the C3 segment. Okay, so it can be this far away to have this artery. So anything can arise from anywhere. That's a very simple message. Okay, so you have to be you have to pay attention to all the possibilities. I don't know what is this about. So this is odontoid arch connecting to here and also to the posterior meningeal artery. Okay, so again, just to remind you again, don't forget the dural branches. They can arise from these arteries. So look at the images very carefully. Never inject anything and think that it's safe because you're in the dural arterial system. Okay. Okay. So comparing this again, so we have a dural shunt. So over here, I didn't put the bone in here, so it's not very easy to appreciate. Okay. So this is a dural shunt at the lumbar level. There's a shunt here, a segment higher, one segment higher on the opposite side. We have the anterior spinal artery. We have the radiculopial artery from one level lower on the opposite side. So it's you can appreciate the anatomy quite well when you're in the spinal level. But at the craniocervical junction level, actually, when you have a shunt around here, everything is so close together. Well, there must be a dural branch which is feeding this, this shunt and refluxing into these veins. But you're really you cannot be really sure that even though you can categorize that feeder, you cannot be 100% sure that you are only in a pure dural branch, not supplying any lateral spinal artery system. So we're not really comfortable with embolizing dural shunts around this area because we are scared of hitting this lateral spinal artery system. So usually we manage these cases using like open surgery and stuff. Okay. So again, the shunt can be like this in the spine. Over here, everything is so close together. It's not, so I've drawn here. It's not very nice. It's not a very nice drawing. So this shunt is at the dura. There's a reflux. There's a dural branch here going at the surface of the dura. And at the same time, very close to that origin, you can have the lateral spinal artery. So they can be even closer together. So it's very difficult to differentiate them on very high resolution angiograms, even though you have a very beautiful angiograms. Okay, so I will move on to the venous system. If you have any questions for the arterial system, maybe I can show you some cases before we move on to the venous system. Or we can continue with the venous system.
There's a quick question from the audience.
Okay, I cannot see the chat. Okay, I will look at the chat. Okay.
Aslan Effendizada is asking, anterior meningeal and odontoid arch dural branch can be used interchangeably. Like, are they synonym in your way to? Okay,
so maybe there was a confusion. I will try to look at the chat. Okay. So to clarify, anterior meningeal and odontoid arch dural branch used interchangeably. Yes. Okay, so in this picture, so this artery is described in some textbook as the anterior meningeal artery. And the odontoid arterial arch system, I think, in my understanding, it's probably the whole system connecting here through the hypoglossal canal and going down to this neuromeningeal branch of the ascending pharyngeal artery. So this is the, and also here to the opposite side. So this is the odontoid arterial arcade over here. So this is a just one component. The anterior meningeal artery is only one component to that system, in my understanding. The same thing goes with the probably the posterior meningeal artery. Okay, the one that runs in the midline, supplying the falx cerebelli. Many people just name them posterior meningeal artery, but some of the people will prefer to call them artery of the falx cerebelli. Correct me if you have some other ideas or understandings.
No, I guess part of like learning this is just becoming comfortable with like different names from different, people, different schools of anatomy, whatever. That plays a big role when you look at like, say,
yeah, sometimes it makes it create confusion, like the clival branches that arise from the meningohypophyseal trunk of the ICA. In the textbook of anatomy, textbook of Rotten, it is as described as what was that? It has some other names. Okay, I cannot recall that name right now. Okay. Anyway, there are different, it's like not really slangs, but different ways to call, the same structure. So that's why it make things quite confusing. Like the ILT, the inferior lateral trunk, in some of the texts, they will be called the artery of the inferior cavernous sinus. So, sometimes it creates some confusion. Okay.
I think another thing that may cause confusion is the fact that there is another anterior meningeal artery, right?
Yeah.
So which one? When you say anterior meningeal artery, what do you mean? Do you mean the one in the anterior cranial fossa, or the one in the?
Yeah, exactly. So we have to be careful who's speaking about what, and it's Pierre Lejeunesse used to say, like, anatomy is like a language. So you have different names for the same thing. You can call, in English, probably it's not very different. Maybe UK and US different names, same thing in anatomy too. We should use the same name, but still we have our preferences. Okay, so I'll move on a little bit. It's probably a lot of information, but anyway, in the for the arterial side, you can have like in the spine, different components from any segments. Okay, so just be careful about those variations, and remember that the arteries are very small, that you cannot always see everything. Okay. So the venous system at the craniocervical junction, sometimes it helps you to manage the case when you have a shunt in the hypoglossal canal or the anterior condylar vein, or sometimes they are called the shunt at the anterior condylar confluence over here, or it can help you to guide your microcatheter through the IPS to treat a shunt in the cavernous sinus. Okay, a lot of names.
Pong, can you go back to that image?
This one?
Yeah. Can you tell us what view are we looking at this sinus? Like, is
okay, I have. It's so this is the foramen magnum. Okay.
Okay.
So this is not a perfect drawing. I have some 2 or 3 other variations that I have put. This is one of the first drawing I tried to make of this area. This is made for myself, because I wanted to get a 3-dimensional image of the structures here. So it's not a very perfect drawing. So this is like an oblique view, posture, oblique view.
Medial to lateral.
You can, yeah, so this is the midline. The foramen magnum is cut at the midline and medial to lateral, yes. Okay.
Thank you.
Every drawing from now will be drawn from the same angle, but a little bit probably nicer later on. Okay, so this is just the introduction. Again, we have a lot of names here. At the end, you should be able to tell which one is which. Some you're quite familiar with, like the inferior petrosal sinus is easy. Okay, sometimes we know about the name of the anterior condylar confluence, but we don't really probably not really confident when we see the picture where it is. Okay, so speaking of the major venous drainage, so it is told that if you're like in upright position, it will drain using vertebral plexus more, and if we are at the supine position, it will drain more in the internal jugular vein. We have talked about this in the previous banana course. So this is the usual thing that we see on angio, but sometimes we see something like this. It drains more on this. No, it doesn't drain very much to the internal jugular vein. So this is there are two types of drainage of the this system. So the one that deals with the vertebral venous plexus drainage will be a little bit not, a little bit complicated. These are names again of all the on the components that has something to do with the anatomy in this area. Okay, this is a schematic drawing. It's to make things a little bit simpler. Again, this is from medial to lateral view, posture, oblique view of the system. Okay, so what we name as, I didn't put the name here. So this is the anterior condylar confluence is here. It's like a confluence, as we call the confluence. It means that things are, merging into one point. The drainage will merge into one point and have like, it can go from one direction to another at that point. So it's a major connection of many veins that we see around here. So one of the major structure that it might help you to recognize other structures should be the anterior condylar vein, which is the vein of the hypoglossal canal. The hypoglossal canal is a constant structure. It has a vein that goes inside, and it connects to the venous plexus inside the vertebrae. Okay, so this is one structure that is very constant. It's constant, and it's very easily recognizable. The size of these anterior condylar confluence can be large or small, sometimes really difficult to see. And also the connection of the inferior petrosal sinus, it can be directly here. It sometimes connects to the anterior condylar confluence, or it can be like you have one connection here and another connection there. So these connections are not constant, but it can be like anywhere because it's the vein. Okay. Okay, so maybe we look at some pictures to see the structures that we are trying to recognize here. So the same drawing again. Well, sometimes we have a shunt over here. It's so black and everything, you don't really see the small structures. So again, we go through the 3D. Again, the same drawing from the same angle. It has improved, huh? Probably this one is probably easier to recognize. This is the C1, the bone of C1, and we have cut at the midline. So this is the jugular foramen, okay, and this is the hypoglossal canal. These are two structures that they are quite easily to recognize. Okay, so this is very easy one. This sigmoid sinus going through this to become the internal jugular vein, and usually have the IPS connecting through there, a little bit extracranial sometime, and the anterocranial confluence, condylar confluence, is actually an extracranial structure. Okay, it's extracranial. And again, the one that is recognizable is the hypoglossal canal here, the anterocondylar vein, connecting to the internal vertebral venous plexus that runs along, the surface of the dura inside the spine. Okay, and there are some other small veins running in front of the vertebrae, and another one a little bit laterally. It's called the lateral condylar vein. Another one that is interesting, there's a posterior condylar canal here. It has a connection anteriorly, extracranially. It runs to this canal, and again, it connects extracranially again here. And they can have connections to the anterocondylar veins and also to the internal jugular vein also. So sometimes it becomes quite complicated. So after having looking at this, take you through the real life 3D thing. So this is the internal jugular vein. This is the sigmoid sinus, and this is the inferior petrosal sinus, and all the stuff here that it's quite complex. It looks complex, but I will turn this around. Okay, might be too fast. Maybe I stop here at about the same angle as the drawing. Okay, so you can see here there are connections. One is through here, the other one is through here. So this is the anterior condylar vein over here. Another one more laterally. This is the posterior condylar vein over here. I'll make it turn a few times. It runs like very close together, like parallel to each other, very close, and there's one connection in between. Okay, so where is the anterior condylar confluence? It's not a round structure actually. So this is the I have to go back again. Okay, so this is at the, sorry. So, okay. So this is something that runs anteriorly. So this will be the prevertebral venous plexus. The other one over there will be the lateral condylar vein. It connects to the external carotid artery of venous system. And so the part that connects all these structures together is over here. So we can say that this area is the part that we should call the anterior condylar confluence over here. It's not that large. It doesn't look like a pouch like in the drawing. Okay, so we look again with the bone, similar angle. So this is the, not exactly the same angle. I should turn it around a little bit more. Okay, so this hypoglossal canal. So this is anterior condylar vein. Okay, so this is the posterior condylar vein here, a little bit lateral to that. This sigmoid sinus, jugular vein, inferior petrosal sinus. We see one here running in front of the C1. So this is the prevertebral venous plexus. Another one quite laterally. This is the lateral condylar vein. So everything connects to this area, which is the anterior condylar confluence. Okay, so once you have a shunt in this, around the hypoglossal canal, you have to guide your catheter through this like maze, and have your catheter position at the shunt point to put the coil to embolize efficiently. Okay, the same thing, the same case in the axial view MPR. Okay, I'll run you through. Okay, I'm trying to stop at the hypoglossal canal. Okay, so this is it. Okay, hypoglossal canal. Maybe a little bit more like this. You can see it's running like that. Okay, and this is a connection to something lateral to the hypoglossal canal. This one is extracanal and extracranial. This is the posterior condylar canal or posterior condylar vein. Okay, so the connections to everything is around here. So this is the anterior condylar confluence. It's an extracranial structure. Okay, and you can see the IPS connecting here through. Okay, we can do this over and over again. It doesn't move smoothly as I want it to be. Okay, maybe we can run it one more time before we go to the next slide. Okay, look here. So this is a posterior condylar vein coming up. It's here. Okay, anterior condylar vein, the part that connects to the IPS. Okay, so these are the major components of this area. So if you have a shunt over here, you have to, like in this case, you have to turn your microcatheter all the way up to here to place the coils inside this, the shunt point. Usually it's around the hypoglossal canal. So you only need a very small amount of coil to occlude the shunt. Okay, so some other veins that you might have heard of, but usually not very well recognized, is maybe one of them is the inferior petroclival or inferior petro-occipital veins. Again, two names for the same structure, okay? Inferior petroclival or inferior petro-occipital vein, okay? The same structure. Okay, where is this vein? Again, you can see from this rotational venography, this is the junction of the IPS to the internal jugular vein. So this is the IPS itself. There's another structure running parallel to this. And actually this is, the IPS is more posterior than the other structure. So this one is actually the inferior petro-occipital vein, or even some of the people will call this a sinus. It shares exactly the same path or the same, curve as the inferior petrosal sinus. So it can be, misunderstood as the inferior petrosal sinus. But the big difference is if we put this on with the bone, you can see, that the IPS runs inside the bone intracranially, but this paired venous structure, the petroclival vein, is actually an extracranial structure, as you can see here, that it runs outside the cranial cavity. Okay, so it's outside the bone, but it leads you also to the cavernous sinus. So it can be one of the routes you can put your microcatheter in to reach the cavernous sinus. Okay, on the MPR, it looks something like this. Go back. Okay, one is, it's very close. Maybe you can see it better on. Okay, so maybe this side you have so many vessels, maybe this one is easier to see. This is the IPS, this is the inferior petro-occipital or petroclival vein, okay? So like this on the this drawing. Another one, this is not something that we put our catheters into. It's called the internal carotid venous plexus of Richtorzik. It's quite difficult to recognize. This one happens to be here and here. So this is the IPS, is on lateral view. It's like this, not a very large structure, but on 3D, you can see it's really actually, you know, encircling this, the internal carotid artery as the venous plexus around the area. Okay. Okay, so that's about the end of the talk. So, well, this anatomy can help you manage the shunts in the hypoglossal canals, and also sometimes when we run into a case like this, so this is a shunt at the, you know, around here, this the transverse sinus, the sigmoid sinus, and a little bit over here too. We weren't really sure where the shunt was, but it was like kind of like refluxing because there's no outlets. It's like the sinus isolated. It's refluxing, and the patient came in with the intracerebral hemorrhage. So we went in to embolize this thing transvenously. We started out like this, going a little bit more, and we ended up having something like this. This is good enough to cure the shunt that was refluxing into the cranial, intracranial venous system, but we still have a little bit of shunt here, and we could have left it alone. But after, you know, some analysis of the pictures, I just thought that we can get rid of everything and still like this, and still we can spare the venous anatomy around the area like this. I think this is very cool. You know, we embolized everything here. We embolized, we placed a little bit of coils over here and some over here, but we left the space between these two, you know, masses of coils. For what? It's difficult to appreciate here, but you can see the IPS running down here through this anterior condylar confluence, which I left over here, opened over here, going through the lateral condylar vein over here into the venous plexus over here. It's not really necessary to spare that, you know, anterior condylar confluence, but just to show you how we play with anatomy over here. So in pink, this is like the shunted blood. So it's involving this area too. So in purple here, this is the normal venous anatomy thing. So it's like kind of like it shares the same venous structures, but we have some shunt points over here and also a little bit over here, not in the middle. So we just place some coils like that and sparing the IPS running down here, running through this anterior condylar confluence and going extracranially. We could have embolized it and it will find other paths. But anyway, this is just an example to show you that this one is, you know, the connections we can, if we, so this is on the follow-up angiogram. You can see it a little bit better. You have a vein going passing through these two coil masses and just going out extracranially. So it's just playing around with your anatomy. Okay, I think this is the last slide I have to show you. I'll stop here. A great time for discussion or questions.
Thanks so much. This is awesome. Of course, it's very complicated. I just put some stuff on the Zoom chat, but everyone encouraged to. There's a lot of this material has in our previous lectures, previous speakers have covered portions of it, and so it starts to, like, once we accumulate more material, it starts to look like more of a library. So there's previous sessions where there's some good cases. Frederick, for example, showed like a really nice condylar type fistula. Goetz did a really nice thing on cavernous sinus, and a lot of the approaches there, and some of the anatomy reviewed. Peter Clival stuff that's in there. So please go. I mean, it's, you know, you have to listen to the lectures and whatever. And a lot of you know this already, but it's there for you. Okay. Any questions? Anything? Comments? So Dodi commenting. You know,
Kitty Pong, usually can you recognize this the vein, you know, there are like the hypoglossal canal one, the posterior condylar vein usually are recognizable on cross-sectional imaging. How about the rest of the peculiar anatomy there? You know, sometimes with MRV these days, like with contrast, can be very high quality. What's your experience with that?
Not all of them are constant, I believe. Even the, you know, I think the most constant one is the anterocondylar vein, and even the you know, the connection of the IPS to the internal jugular vein. It's quite difficult to see on contrast enhanced MRs or even CTs on many modalities. And the variance that we, you know, the variations or the percentages of that we see each structure is not very constant through studies. Maybe it's the limitations of how we see the veins, but I think the contrast enhanced like MRs give us a lot of information about these veins. I think if you want to see if it's really there or not, yeah, contrast enhanced MR is a very good tool to look at these veins, I think.
I would say it's more surprising how constant some of them can be. Like considering how veins are, right? They're definitely tons of variation, but like the condylar confluence is a fairly constant structure.
Yeah, it's yeah.
What contributes to it may change. You might have a bigger anterior condylar vein or whatever, but the structure itself as a confluence of veins, just like a cavernous sinus, as like is a variable, but you can recognize it in most people. And it's an important anatomy to know. It's a little confusing, but to the extent that it like applies to fistulas, like a hypoglossal fistula, it permits, and we talk about it all the time, like recognizing this anatomy does two things. Number one, it permits safer embolization. Like the first thing is obvious, like, you know, okay, there's a fistula of the, you know, of the hypoglossal canal. Well, guess what? The hypoglossal artery is probably going to supply it. And you want to be careful with that because there's a nerve that goes with that. That's number one, that's basic. But the other thing is that once you recognize that anatomy, it permits super selective treatments, like what you show. And we talk about all the time, we cover that a lot. Just once you know where the disease is, once you understand the anatomy, a lot of these diseases, that the actual point of fistula is a discrete thing, right? And when you recognize that, there's a spot there where it's very vulnerable, and you don't have to shoot it with a giant cannonball. You can just take a little thing and you can kill it where it's really vulnerable. And that, number one, it's elegant, and number two, it's safer. The less material you put in, ultimately the safer it is because you're targeting a smaller area. So a lot of that, like we've talked about it, and I want to belabor the point, but like why we learn all of this stuff is to make things safer and to make them more effective. And in that area, that applies a lot. All right. Anything else? Let's see. So we have some cases. I just wanted to, I guess, another thing, maybe just to take a minute. I just wanted to emphasize Kitty Pong's point in terms of the arterial anatomy. So there's a lot of what he talked about has to do with, you know, that the stuff is dural peel, like it's really hard to like where is it, all of these connections. And I think it's like important to recognize that it's not unique to the craniocervical junction. As you mentioned, there's nothing different from what happens everywhere else. In the spine, in the rest of the spine, we see that a lot. You have the names, like for all of the problems that Cody points out and we point out, the names of the vessels sometimes reflect that. So a radicular dural branch, right, is the name of a radicular dural branch is the name of the radicular dural branch, and in the name itself, it tells you what like that there is that it spans two systems, right? Radiculomedular radiculomedullary artery, like, right? So that's a radicular artery, medullary, but that comes from the radiculodural branch. It just depends where you are in the system. If you're a little bit more proximal, perhaps you could have connections to PL and dural systems. The more distal you get, the more distal you get, and the more like super selective your catheterizations become, and the more selective the stuff that you inject there or put there potentially. But I think it's just, we have to recognize that that's not a unique thing. It's just the area is very sensitive. The connections are many. And we certainly have, the technique is something that we don't, perhaps we should emphasize more in the future lectures, is the technique of like, how do you understand, like one is the understanding of anatomy. The other thing is like applying this understanding, like how do you acquire these images, that appropriate dyna CTs or whatever you want, Baso CT, whatever you want to call it. Like in many instances, that information, if you look at it carefully, it's going to tell you like where stuff goes and what you need to avoid. And so we'll devote some of the future stuff to like talking about.
Yeah, I think that's a very important point, because once you learn your anatomy to a point, and you try to achieve those anatomy structures on your images, and once you get the images, you look back at your anatomy and you find more than you know or more than you have learned, and you go back to to study again. It's like a positive feedback on one another. So the more you look into your images, the more anatomy you know, and also some of the structures you don't realize that they are there. So you go back to study your anatomy again. It's a very a good thing when you try to play with your images.
Sorry, if I may say a couple of words. I'm Dodi.
Hi.
Hello, everybody. I would like to just take the example you just made, Maxime, about the radiculomedullary artery or radiculodural artery. Like if a radiculomedullary artery does not have anything to do with dura, and radiculodural does not have anything to do with the spinal cord. That's not true. Absolutely. So yes, we see radiculomedullary and nothing on the dura, but because our examinations and our the detail of what we see is very well gross. We need, if you are a surgeon and you go there and you look with a microscope, you would see that there are arteries everywhere. And so the radiculomedullary artery does give branches, which are so small you don't see them, to the dura. And exactly the opposite, the radiculodural will give branches to the spinal cord, but they are so small that you don't see them. That does not mean that we should always see them. Meaning that you can get by embolizing that artery without having any complication on the spinal cord if you don't see it. But from an anatomical point of view, you certainly have arteries and branches that go to the dura and to the spinal cord, coming in every case when you have a radicular artery. That's what I wanted to say.
Dodi, thank you. I'm trying to find a case that perfectly illustrates what you're saying. Eitan, I don't know if you have, remember that case of the anterior spinal aneurysm with a completely reorganized anterior spinal system?
Yeah.
We could take a few minutes just to show it if we have it, but I don't.
Yeah, I'll look for it.
Anyway, why don't we, let's go ahead. We have a couple of, maybe we'll look for that in the meantime. We have a couple of cases that have been submitted. Omar Chaudhry, I think I saw you earlier. Are you there? Just unmute yourself if you are.
Can you guys see me okay?
Yeah, we got you.
Okay, perfect. Let me just share my video, my screen, and see if you guys can see it. Yeah, I'm having trouble sharing my screen. Is there a way I could do that, Maxim?
Yes, you know what? It's my fault. I guess again, uh, I again I forgot to do this. That should help it. Thank you. Yeah, all right.
And let me know if you can see my presentation mode now.
Yes, perfect. Yeah,
Cool. So thanks, Kitty Pong and Maxim, for showing these anatomical things. It's very useful, always a learning point for me. I just wanted to share a few cases here, and love to hear your guys' thoughts on how they could have been managed differently, and if there's any anatomical pearls you guys have to add to it. The first one is I had this lady, 75-year-old, who presented with new onset left-sided weakness and had a history of trauma, was involved in a major motor vehicle accident 10 years earlier. And her CAT scan demonstrated this hemorrhage, kind of very focal in the medulla on the left side, and a couple of slices kind of showing that. And, given her acute presentation, she got all the stroke workup and vascular imaging. And this is what her CTA looked like. So there was a little bit more than usual prominence of vascularity on the left side. And a concern was raised that this patient has some sort of an AVM or dural fistula, kind of right at the craniocervical junction. And there was this very prominent ventral vessel that was smack in the middle, and was almost like raising concern if it's a really prominent anterior spinal, or is this some sort of an arterialized vein. So that was kind of the CT angiogram. And I'll kind of run through the axial sequences to kind of go over what it looked like, and I can pause it at any point as well.
So I think if you follow, maybe we can try to say if it's an artery or a vein.
Yeah, let me see if there's a way for me to.
Based on this, it seems like a vein. It makes sense to be a vein.
Yeah, it seems like it runs very close to the surface of the the brainstem or the cord. Yeah, it looks more like the vein.
Absolutely, and that's what we thought as well. And I'm going to show you the angiographic images, but I thought the CTA here was very useful. And once we had the angiogram in terms of parsing out the anatomy.
Stop here.
Yeah.
You see
that's
how
the vein.
The vein is actually like more posterior, as Kitty Pong said, is more adjacent to the brainstem.
Right. And you can kind of follow it right here. And as we come down right at the vertebral artery, this is kind of where it seemed to be the fistula site where everything started, right at the left vertebral artery entry point into the dura. Anyways, so we ended up getting an MRI as well, and that showed the area of the hemorrhage and also showed some vascular flavoids, and probably should have gotten some better sequences with thin cut post-con images, but everything that we got didn't really capture the exact angioanatomy of the fistula. So we did the angiogram, and there's a couple of runs. So this is the left common carotid artery injection. This is just a still image, and you can see the filling of the internal and external. And I thought that this image kind of best captured the site of the fistula right at the craniocervical junction. And this is that structure that was kind of running right in the midline there, which is the arterialized vein over here. And I'm going to do a run through of that as well a couple of times. And I'll show the vertebral artery runs as well. And you guys feel free to make comments as I'm.
But it would be good to like, I mean, here, which artery do we think this is?
Right. So my thought was that this was the hypoglossal branch of the ascending pharyngeal that was essentially fistulizing right at the hypoglossal canal. and then draining into the anterior pontomesencephalic vein, or the anterior medullary vein right here, and then subsequently draining into the transverse pontine vein and the IPS and the internal jugular. I'm going to show a couple of better sequences here. So this is the injection from the lateral view from the left common carotid artery again, and that kind of demonstrates that same anatomy that I think we were going over before, where you can see this feeder off the ascending pharyngeal, the hypoglossal branch, the fistula site right here, and the arterialized anterior medullary vein here, and the transverse pontine vein here, then draining subsequently into the IPS and then into the internal jugular vein. This is the injection from the right vertebral artery, and kind of showed the area of fistula much more clearer right over here, and a small portion of the odontoid plexus lower down seen over here. And then this is another angiographic run from the left vertebral artery that demonstrates the same anatomy. So it seemed like the fistula point was the same, coming from the left common carotid artery injection and the left vertebral artery injection, which was all focused right at that V3, V4 transition point at the dura, at the hypoglossal canal.
When on this right vert injection, was the feeling of the fistula from the reflux to the left vert, or is from anything coming from the right?
It was from the reflex. That's a good question.
Okay.
Yeah. And then this is a lateral view of the left vertebral artery injection, kind of demonstrating the same thing. And I thought I could see the anterior spinal artery a little bit more separate from that arterialized vein down over here.
I think there we might differ a little bit. Could you show if that's an artery or a vein?
It's kind of hard to parse that out on that lateral view. Let me see if I can give you an AP.
I echo Max, because you showed before that that drainage is mostly up, but there is also a little anterior spinal vein going down, very little, much more, much smaller than the part going up.
Yep.
Better from the
Yeah, so I agree. But I mean, it's very hard to differentiate that from an artery. But I do agree with you. I'll show you some 3Ds that there was a component which was going straight down as well, which was much smaller, which kind of makes sense.
Certainly, you want to think that it might be an artery.
Yeah. So then, basically based on all that, this is kind of what the anatomy was coming down to be. The supply was from the hypoglossal branch of the ascending pharyngeal and direct dural feeders from the left vertebral artery. And the drainage was into the anterior medullary vein and, the transverse pontine and IPS and internal jugular, as I showed you. And I found this nice paper which has been published that kind of characterizes these different types of hypoglossal canal dural fistulas depending on the venous drainage, whether it's anterograde, it's a retrograde orbital going through the cavernous sinus, or coming more perimedullary. Kind of follows the Conyard-Borden in terms of the severity. But the type 3, which I thought this was, are fairly rare, it turns out. And this is kind of, some of the cross-sectional anatomy that shows those connections. Again, I think the images that Kitty Pong showed were a lot better in 3D, but kind of gives the same taste of the anterior medullary vein and the condylar complex and how they're all connected in this scenario. And this is that paper that I was coding right here. So, looking at that anatomy, I think, the question for me was whether an endovascular route is better or surgical. And my concern was that given that hypoglossal branch of the ascending pharyngeal, there's a risk of giving the patient a hypoglossal palsy by embolizing through that ascending pharyngeal branch. And I wanted to get what everyone thinks would the group would have kind of gone for the ascending pharyngeal embolization.
Okay. Before we go on, I would like to, raise a discussion on what people think where the shunt point really is. You know, in that paper on the hypoglossal canal shunts, well, you can include so many things into the same group. Any shunts around the area you can include into this hypoglossal canal shunt group. But in the typical type of hypoglossal canal or the anterior condylar confluence shunt, usually we have the supply from the not only the dural branches, but the supply will come from the branches, the transosseous branches also. Like it's a little bit more related to the bone, but this one is more like a little bit more posture than the typical, hypoglossal canal dural AV shunts. What do you think?
From this perspective, can you show again that ascending pharyngeal, like the first run?
Yeah, the lateral view.
Which is probably the best to make this analysis.
I think it's a little bit more posture than the actual,
Can this be not a dural fistula, but almost like a PL fistula?
Mm-hmm. But this will be like a PL fistula receiving a supply from this dural branch.
Yeah, but
because
we know we know in
but
that area
that's possible. Yeah, that's possible. But anyway, this is more posture. We are already outside of the hypoglossal canal because it's closer to the entrance of the vertebral artery into the dura. It's like as Omar has said, it's just at the site that the vertebral artery pierces the dura. So it's probably more posture than the length of the hypoglossal canal itself.
Omar, can we go back to the CAT scan?
Yeah.
I think, and we emphasized this before, I think it's very important when you're understanding these lesions to get a good dynasty or like a rotational, if there's like, depending on what machine we have, most of them have this capability. Like it's valuable in understanding exactly where the shunt is. I think here we actually have a pretty good idea based on the, here, fortunately, oftentimes they're venously contaminated. So if we go, I know it's hard to stop it at the right moment, but
should be very soon.
Go back, yeah.
Very close, yeah.
Go back.
A bit more.
Okay.
There.
All right.
So that to me seems it's intradural. What we're seeing is intradural. Like if we put together our anatomy, like our this anatomy, cross-sectional and the angiogram, it seems like that the shunt is intradural.
Yeah, I have the same assessment. I think that's a very astute comment. So what do you guys think then in terms of treatment options here?
Go back a little bit high. Like let's see the hypoglossal contribution.
I think it's gonna have to go through the whole loop, Max, but let me just do that again.
Now you see that spinal vein. You see that anterior spinal vein?
Yep.
Yes.
So that's, I mean, that obviously. Yeah, okay. Forget it. Probably in the interest of time, we should move on.
But there was an enlarged hypoglossal branch. You see it smooth going through and then.
Yeah.
I mean, the problem with in the vascular disease is that, as you can see, there are all kinds of dural to PL connections. So I think if you elect endovascular, the hazard is basically the risk here. At least if you're like, if you counsel the patient, what's the risk here? The risk is a lateral spinal infarct.
Yeah,
I think is the most likely local issue that would arise. The hyper. Probably should mention, so the original presentation was a lateral medullary, think a venous hemorrhage? But
it was a hemorrhage, correct, yeah.
Mm-hmm.
Why hemorrhage? What do we think is going on? Why is it bleeding? What's bleeding?
I mean, I
So
would
it's-
assume that it's, I mean, from what I was reading, I mean, if you're really calling it a, you know, a type 3 hypoglossal fistula, and it's, I agree, it's a little bit more intradural. I mean, venous hypertension, and, you know, I didn't really see an aneurysm or anything associated with it, but it's some sort of a venous hypertension leading to a hemorrhage, I guess.
Yeah, I think Luca was asking also on the chat, like what, but do we see a varix there? We don't really see a venous,
No.
unless it's thrombosed or something.
Yeah.
We don't,
So, so guys, I'll move on in the interest of time, but essentially because of the same things that, you know, Maxim and everyone else is pointing, the concerns were, you know, the risks of, you know, medullary infarcts and all the peel contribution. So decided to go towards a surgical route. And I just wanted to show some pictures because we rarely see anatomy kind of at the cervicomedullary junction in that location. And again, this is not to promote, you know, surgical treatment for fistulas, but to say that, you know, sometimes your hands are tied. So this is, you know, the surgical view. I just want to point out some anatomy here. This is essentially looking from top down. So this is the top of the head at the bottom of the slide, you know, the feet are towards the bottom. This is the cervicomedullary junction, the lower portion of the cerebellum, and you can see the vertebral artery V3 segment right here, right where my cursor is, and this is the point where it's actually entering the dura, right here. And the C1 arch has been taken back right over here. And this is the condyle, which has been drilled back. And this is the cuff around the vertebral artery V3 segment. The next slide is after we have opened the dura. And this is kind of what things look like. So this is the lower portion of the cerebellar tonsil, which has been pulled back. This is the vertebral artery going through the dura. So this is the dural cuff around the vertebral artery. And this is the pica loop coming down. This is the cervicomedullary junction right here. And you can see the rootlets of the hypoglossal nerve right over here. And you can clearly see that there is a lot of increased abnormal vascularity right over here. And by studying the anatomy and the angiogram, it seemed like that the connection from that shunt to the anterior medullary vein was right over here. So this is that arterialized vein right here. And you can see there are multiple feeders kind of all coming right at that entry point of the dura. And I think the interesting point was identifying the lateral spinal artery in this location was very interesting because it's actually hidden right over here. And it was basically an en passage vessel that had to be saved while obliterating this fistula. This is another view that kind of demonstrates the same thing. And this is a little bit more anterior ventral view that shows that arterialized vein right over here at the fistula site at the craniocervical junction. And this is the vertebral artery, as I showed before, entering in and going into the V4 segment. We do this endocyanine green angiography, which is kind of like a poor man's angiogram in the surgical field, just to show the shunting. And this vein, you can see, is how it's like arterialized because of that shunt at that connection site. And, you know, the surgically, when we obliterate these, we just obliterate the draining vein essentially at the fistula site because there's so many feeders. Taking the vein essentially is the easiest way to treat these. So this is essentially the clip that's in place over that arterialized draining vein, which has been cauterized and divided. And we used an endoscope to just kind of look more ventral. And this is a view looking right ventrally, right in front of the clival area and the ventral part, where you can see that vein is now blue since it's been disconnected at the site of the shunt. And this is the ICG that has been done after the treatment. And you can see now it's filling of the pica and the vert with the vein being turned blue because it's been disconnected. And this is the intraoperative angiogram from the left common carotid artery and the left vertebral artery that shows that arteriovenous shunting is resolved. And this kind of shows the intraop 3D dual reconstruction with the clip in place right at that site. And, you know, it shows that the fistula was treated by focusing right at the vertebral artery entry into the dura. Happy to take any comments and questions.
So it's a dural shunt.
Yep.
Yeah. Did you see any branches from the pica contributing to the shunt?
No,
Maybe no.
no. And that's a great question. The pica was dissected out and it was completely separate from the feeders coming from the vertebral and transdural from the ascending pharyngeal. And Maxim, I have one other quick case. Do you think we have time for that, or?
Sorry, one comment. I think it was great to do this surgical, and I think that can be relatively safe compared to an endovascular treatment many times. But any comment from anybody regarding, like, here, maybe was there any route for a transvenous endovascular approach to this?
No, I don't think transvenous will work. Huh? It's not the true hypoglossal dural AV shunt. So it's more like spinal thing.
Yeah,
spinal
so,
dural AV shunt.
Like, is it? Do we think it's impossible to go retrogradely through that anterior pontomedullary vein?
Haha, who dares?
I think it's one of those, if it goes well, it will be a great case to show, but it could go very wrong too. So I'm just going to hop onto this very quick one, Maxim, if you would allow that.
Yeah, let's go ahead. We have one more case after this.
Okay. So I had this 69-year-old lady who came in with complaints of slurring speech, a lot of heaviness on the left side of her tongue, had really bad left-sided pulsatile tinnitus, and these are her pictures of, and she had really a lot of atrophy on the left side of the tongue and had a left-sided tongue deviation, and she just couldn't talk normally, a lot of slurring in her speech. She was had seen a lot of doctors, and just nobody was able to diagnose what's going on with her tongue. And then this is kind of the key images from her MR and CAT scan. And you can see the increased vascularity of the clival bone here, and really the enlargement of that condylar complex and the jugular venous complex that Kitty Pong and others have shown today and before. This is kind of what the angiogram looked like. This is the left common carotid artery injection, AP view, and the lateral view, and the left vertebral artery injection. And these are the right-sided injections from the external carotid artery, AP and lateral views. One thing I've learned with these condylar fistula, and I don't know others in the group would agree or not, is that I feel like because they're so fast flowing, sometimes while treating them, I always, for control injections, like having the catheter in the opposite artery where the flow is, a lot easier to see where the fistula point is. And this is kind of a good view from the right ECA injection where you can see these feeders from the ascending pharyngeal kind of going across through all that vascularized bone down into that anterior condylar complex where the fistula site was. And it's so hard to see that fistula point looking at that left-sided injection because it's so busy, because the supply is so much. But just by having that as a control injection always helps me in making sure that I'm not like missing the fistula pocket while selecting it and making sure that I'm obliterating the whole thing. This is a few injections right here. Essentially, I don't know why it's not playing, but it's the same concept. And we decided to go with a transvenous treatment with coils. So this kind of like summarizes, I think, what has been described really well by Kitty Pong and others, is essentially just parking the catheter transvenously and trying to navigate into that fistula pocket off the internal jugular vein and to coil out and pack off this pocket. And that's what it was completed. And what was most interesting in this case was this lady 6 weeks later. This is a picture of her tongue, and it's really amazing how like some of that atrophy can actually be reversed. And, you know, a lot of people say that, oh, you know, coils have mass effect, and I don't know if the hypoglossal nerve is really going to recover. And I think it makes the same point we see with, you know, third nerve palsy caused by PCOMs, and, you know, putting pipes and coils in them. I mean, these people do improve a lot. And this is a lady on the follow-up, and she made a good recovery. So I just wanted to kind of make the point of like hypoglossal palsy seen from these condylar fistulas.
That's beautiful. That's an amazing case.
Great. Thanks for letting me share.
Yeah, that's very interesting because like for like in the case of cavernous sinus dural shunts, sometimes people say that after embolization we have abducens nerve palsy because of the coil compression. But most of the time in those cases, they're not actually coiling the exact shunt points. You know, they are coiling other compartments, so they have to put a lot of amount of coils just to stop the shunt because they're not at the right spot. If you're at the right spot, you probably only need the minimal amount of coil to occlude the shunt, as you've done in this case. So. But I've had a case that the patient had like a atrophy of the tongue since like 10 years ago. I did something, but it didn't come back. Maybe also the length of the symptom is the one of the point of the recovery too. How long has the patient had this atrophy of the tongue? How long is it?
So her symptoms had been going on for around 6 months.
Okay.
Initially, it started with just pulsatile tinnitus, but then she started having speech issues and the tongue stuff. That's when she like sought care. So I think the tongue stuff may not have been there for longer than a couple of months.
Okay, but still, it's a couple of months, still reversible. It's very interesting to know. Thank you.
Yeah, you're welcome.
Omar, thanks so much. It's just so much great anatomy.
No, thank you for letting me share. These are. I just want to give credit to you guys for the Neurangio website and what you guys do with these sessions. It's something that I really enjoy and have learned a lot from you guys. So thank you.
Thank you. Thank you. Thanks. All right. So Frederick, thanks for waiting. Been waiting patiently. We have one more case, I think.
Hi everybody. So
Thank you.
could you see my screen?
Yes, it's just starting. Yeah, we got it.
So hi everybody. It's more a case related to the previous session. It's a spinal heavy shunt, and so this is a 65-year-old female with a progressive onset of sensitive disturbance of the inferior limbs and sphincter disturbance for 4 years, which are worsening recently. So she has this spinal cord MRI. So you have this hyperintense signal at the central aspect of the spinal cord, but you don't have any flow void around the spinal cord. So at the beginning, the neurologists were thinking about a glial tumor, but they asked us our opinion and referred us for spinal DSA. So you have this shunt. I'll show you once more. So it's a right L3 lumbar artery. So you have dual feeders which are connected to the anterior epidural plexus. You can see here with the connection here with the anterior epidural plexus at the upper level. So you have all these dual feeders. The shunt point is here, and you have the early opacification of the anterior epidural plexus, and you have a reflux in this radicular vein, which will contaminate the normal venous drainage of the spinal cord. So you know that the difference between dual and epidural fistula. Epidural fistula are more frequently located at the lumbar levels, and usually you have bilateral feeders in epidural fistula compared to dual fistulas. So what should be your strategy for the treatment of this patient? When we look at the literature, the surgery looks to have better results compared to embolization because the rate of recurrence after surgery is less than 5%. And in embolization, I think this is the experience that we have. We have recurrence as frequently as in 40% of the cases. So it's very frequent. And when you decide to embolize, according to this meta-analysis, if you use EVOH, you will have a bad result because we know that when we inject EVOH in the segmental artery, usually we have a lot of reflux until the aorta, and you have to stop the injection. So to treat this patient, because there is a huge shunt with a lot of feeders, and the goal is to fill the epidural, the anterior epidural plexus with embolic agent to be sure that we cure the fistula. So we used a technique that we developed, and we have been inspired by René Chapeau. It's a cooker pressure technique for the spinal cord vascular malformation treatment. So this is a drawing that my wife helped me to do. So it's very difficult to put a 6 French, sometimes very difficult to put a 6 French catheter in a segmental artery. So in this technique, we use 2 5 French catheter. So the first one is engaged in the ostium of the artery. We navigate then a micro catheter at the distal aspect of the segmental artery. Then we disengage the 5 French catheter, the 5 French guiding catheter. We put a second guiding catheter at the ostium of the segmental artery. Then we navigate the microcatheter that we will use to inject the liquid embolic agent, so the EVOH. And after, we will coil distally the segmental artery. We will coil the dorsal trunk of the dorsospinal trunk. We will coil retrogradely. We could also inject some glue to have a good cast. And after, we will inject the EVOH through the second microcatheter until filling the origin of the draining vein. So that's what we did in this case. So we have here the first guiding catheter, which is inside at the ostium of the artery. We navigated an echelon microcatheter. To stabilize this microcatheter, we deployed a small stent retriever to be stabilized and disengage the first guiding catheter. Then we navigated a second guiding catheter at the ostium of the artery. The microcatheter of the first guiding catheter is here, and the second microcatheter is here. We navigated as close as possible to the shunt point. We used an Apollo detachable microcatheter with a 5 centimeter detachable tip. And then through the first microcatheter, we coiled the main trunk of the lumbar artery. Then we coiled the dorsal branch of the dorsospinal trunk, and we coiled retrogradely all the segmental artery and injected some concentrated glue to have the cast. And after, through the second microcatheter, which we strapped by the coils and the glue, we injected some squid 12, to occlude all this feeder and to fill the anterior epidural plexus to be sure that we fully occluded the fistula. So here you have the cast. You see the filling of the anterior epidural plexus. You have the cast of the EVOH and the angiogram at the end of the procedure, which shows the occlusion of the shunt. And you can see here the CT scan, which shows you the EVOH cast within the spinal canal, which is inside the anterior epidural plexus. You can see here. And so the patient had a right L3 nerve root lesion, probably from ischemic nature, and she had some pain in the territory of the right L3 and a minor right inferior limb deficit, which was reversible, and the patient recovered under anti-inflammatory medication with no sequelae, and she slightly improved from deficit from the inferior limbs. So if you have any question, any comment on this technique? Thank you.
Hi, I'm Tibor from Raleigh in North Carolina. Thank you so much. It's fantastic. I love this technique of the 2 catheters engaged in sequentially in the origin. It just so happens that I have an epidural fistula that I will have to do in a couple of weeks on an 18-year-old, and I'm pretty sure I'm going to try the same technique. It's very, very neat. I really liked it.
We did total 5 cases with this technique, and we had a complete cure in these 5 cases with a late angiogram, which shows the complete occlusion at long-term follow-up. But nowadays, we mostly use a dual lumen balloon. It's not always easy to navigate them in the segmental artery, but you could use a regular septor balloon, it could work, and even a septor mini, which is a low-profile balloon, and it's even easier to do. But this technique, the Cooker pressure technique, is valuable because it's not so difficult to put two guiding catheter in front of the ostium of the segmental artery.
Now, any issue with removing the second microcatheter after putting a glue cast?
It was a detachable tip microcatheter, so
it was.
I see. We detach it.
Very nice. Thank you.
Have you ever tried to exchange for a 6 French in the ostium? We tried a couple of times. It's something that may work.
That's what I do nowadays. I use like a supple guiding catheter, like a Benchmark or Chaperon. And so I put a 5 French catheter, Cobra small 5 French catheter, exchange guide wire, and then navigate the Benchmark or the Chaperon, and it works. And I use it nowadays for using a dual lumen balloon. So it's another option. But I think the main goal is to be able to inject onyx and to have a distal penetration. But because if you don't use I don't know a proximal plug or a balloon, you will always have reflux. I don't know if it's your experience, but you have reflux in the aorta and you have to stop because you will not inject the onyx in the aorta. So you have to cancel the procedure.
Yeah, no, I think we have the same. I think most people have had the same experience. Like the reason onyx doesn't work so great in spine is because it's hard to have flow control. Like it takes time what you do. Like you have to set up the whole thing. Once you have flow control, like you have flow control, and then I think you can penetrate the vein. Probably a lot of the literature, epidural shunts, and the vascular treatment. The issue is people don't understand these things very well, as much as perhaps even less than dural shunts. And so like that just has to do with under treatment, and then you have recurrence. If you know what you need to occlude, you're going to occlude it, and it's going to be fine. But in counterpoint, Dodi, are you on? Dodi has.
Yes, I am. Yes, I am.
Surgical.
So I've been in hundreds of surgical cases. It's a 5 minutes procedure. And it's so simple and so elegant. You just go to this small vein, everything is finished, and you don't have to do all this stuff. And so for me, surgery has no chance. I mean, endovascular has no chance in relationship to surgery in these cases. Tibor says that he got a referral from a spinal surgeon, but that's a problem with the spinal surgeon. If he doesn't know how to do such a surgery, he should learn. It's simple, it's effective, it's elegant, it's immediate, it's 100% sure. I mean, we have no chance to be better than them. And we can, and you look at these images, I mean, it's not really nice. All that black everywhere, black, and then coils, and then glue, and then 2 catheters. I mean, why?
Why to avoid the spine cracked open?
Sorry?
No.
To avoid the spine cracked open.
Yeah.
No.
If you say it like that, of course, yes. But it's just a small piece of bone which doesn't affect at all the stability of it's a lateral laminectomy. It's nothing. I mean, I've been to 100 and more surgeries.
Dodi. Yeah. And thank you for mentioning that, because I'm about to do the angiogram in a few days. So what I'm gonna do is I'm gonna run it by another spine surgeon who trained at NYU actually. So he's done dural fistulas and stuff like that. So maybe if it's easier for the patient, then we'll try to do it that way if the surgeon agrees. Yeah.
Dodi,
Yeah.
Yeah.
For sure, I think what just want to clarify for the audience, certainly like for spinal dural fistulas, like we know the targeter is that vein, we cut the vein, done.
Yeah.
What about the epidural vein, the epidural stents? Like,
Yeah, you're right. Yeah, I agree with you. The point is that you don't care about the epidural fistula. You just care about the vein which enters the dura. So you just leave it alone, and you just cure the symptomatic vein, which is the one that enters the dura, and you leave it alone. The external epidural fistula. And if you want to occlude also that, well, you can inject some particles. It's simple. And you don't create any problems after surgery, of course. So no, I don't agree with the endovascular treatment of spinal AV fistulas. I mean the dural and epidural AV fistulas. Really, it's of course not every surgeon knows how to do it. Why? Because they never saw one, and if you are not if you have not seen it, you don't know what to do. But once you do it and you see it once, maybe twice, then you understand how simple it is. And maybe our job as neuroradiologists should be to go to the OR and tell the surgeon what he has to do. Just show him, this is the vein, you should clip this and you should cut this. And then the surgeon just does it. And so
yeah, we used to do that on a regular basis and the surgeons would want us to be there just to confirm the anatomy. And I thought it was very useful for both because I ended up learning a lot. And I think the surgeon felt more confident. But yeah, I agree. I mean, it is simple.
And we have so many recurrences. I've seen so many recurrences with endovascular treatment.
Although I have to say that I also got a recent referral who had T11 dural fistula that happened to share the anterior spinal, the Adamkiewicz, and so therefore he was operated on and ended up recurring and got cured with embolization through collaterals. So everything is possible, but in general, yeah, I agree.
You have to have a good surgeon. I mean,
he was a good surgeon. He was a good surgeon. I've done hundreds.
Frederick wanted to answer probably.
No, I just wanted to say that even good surgeons sometimes could miss the origin of the draining vein. They can do a mistake of the level of the fistula, and they can have some wound infection. So they don't have perfect result, at least in my institution, and we have good surgeons for sure. So I think there is a place for embolization, and with such technique which are very safe, you don't have to.
Sorry, Frederick, it's not safe because if your injection, especially with SPRID 12, would have gone all over the vein into the perimedullary venous plexus, you would have caused a major infarct, venous infarct in the spinal cord. And you were lucky that it was very long, the vena before getting to the spinal cord, but many times you are very close to that. And I've seen embolic material going into the spinal perimedullary vein.
It's a controlled injection. You see what you do, and you control your injection.
No, maybe you are so good that you do, but most people don't. And I've seen, especially SPRID 12, which just flows very, very nicely and very far away, that it can go in 1 second. You cannot control it because in 1 second it's already 5 centimeters farther than you want it. So no, it's not controllable when you inject liquid materials, especially the non-viscous one. So if you have a very short vein before getting to the perimedullary plexus, it can go there, and it can occlude veins.
Sometimes favorable for embolization, but here it was very favorable for embolization. And to surgically treat this epidural fistula with a shank point within the spinal canal, I think it's not easy, even for a good surgeon. But
Okay.
I agree that we have to analyze the architecture of the fistula, and they are not all treatable by endovascular means, especially if you have a radiculomedullary artery at the same level or at the adjacent level. But in this case, for me, the risk is zero. What risk do you have?
Well,
Nothing.
he had a complication. The risk is zero, but he had a complication, so it's not really zero.
It was a transient complication, and she
Okay,
recovered.
but you don't know if it's transient until it's over. So it could have been
I think the problem is sometimes we cannot see all these spinal vessels, all the, you know, like the radiculopyle arteries. Sometimes they are very small that you cannot see on every angiograms that you run, even on the 3Ds. But there's a possibility that you can inject into these branches. So there's some possibilities that you know, liquid embolic materials or have the chance to go to cause some you know, spinal cord infarctions. If you do,
but usually when you do 3D rotational angiography with a knee reconstruction, you can see them usually. You don't see them in DSA, I agree sometimes, especially posterior spinal artery, you cannot see them. But 3D rotational angiography with MIP reconstruction in coronal view, usually you see them. And sometimes you have to, I had one case like this, I had to stop the procedure because it was too risky. I couldn't do the technique.
How do you guys, it's a very simple-minded question, I'm sorry, but how do you guys do in the lumbar area? How would you do a rotational angiogram? I tried in the old days, I used to do kyphoplasty. I tried to do these, and I can't make the 3D rotate around the body that low down.
I guess
you can do it. You have to translate the table very distally, and you can do it. We do it
systematically. It usually doesn't have the clearance around the body.
Well, I'm sure the patients in Raleigh are also different than in Paris.
No, even in New York. I mean,
you have total patients.
So
what?
I think the later versions of at least the Siemens equipment have a bigger, so the ladder it allows you to rotate.
I see. Okay. I haven't tried this with my current machine, but I know that the Siemens that we had at NYU, I couldn't do it.
No, I think we can't do it in Romania. We can't do it in the old machine, but on the new.
Right. Okay, so that's what it is. Okay.
I think
got it.
Yeah, no, we always get Dyna-CT for a sacroplasty. It's feasible.
I mean, I think it's amazing the discussion we've had, because I guess it's turning to a close, and we've it's important that we recognize, I mean, whatever, I don't want to belabor the point. Understanding the anatomy is key. If you know the anatomy, you can do it surgically, you can do it endovascularly. We could talk a lot more about the safety of epidural versus dural fistulas, and maybe Dodi, we should raise this whole idea of permeating of medullary veins with liquid embolics. It's a little bit under-recognized and goes to your point. But at the same time, we're a little bit out of time. But it's a really nice case for stimulating discussion, Frederick. Thank you. So this is what it's all about. Thanks everybody. We got to go now. We'll put this up on the. It'll be on YouTube. Any other last comments, questions? We'll see you in a month. We'll figure out what we're gonna do next month. Okay.
Thank you, Max.
Thank you.
Everybody have a nice evening, day, morning, night.
See you soon.